Hi, I'm Dr. James Thomas. In this series, I'm going over how to visualize nerve function in the larynx. In this video, we're going to take a look at one muscle, the lateral cricoarytenoid muscle. And you can't see it, it's out far in the larynx, but what we are going to look at is the effect of this muscle. And to focus on the lateral cricoarytenoid muscle, we want to focus on the vocal process. And if I use my arms here as the vocal cords, the V shape of the vocal cords, the vocal process is going to be my wrist. And we can watch two things. We can watch phonation on stroboscopy, and we can watch breathing, and breathing is often missed. So when you're recording with your endoscope and you want to see what the lateral cricoarytenoid muscle is doing, train your eye on the vocal process, and we'll look at a bunch of normals. So during breathing, the vocal process is going to move. In general, when you breathe in, they open up, and when you breathe out, they close partway to resist airflow. But they do more than one thing. There's translation, that is, the vocal process moves from lateral to medial with each breath. But there's also rotation of the joint, and that is when the joint moves medially, it rotates inward, so that's expiration. And when you breathe with inspiration, the joint rotates laterally. So there's translation and there's rotation. And keeping our eye on the vocal process, we'll be able to watch a breath in and out, in and out. And with phonation, we expect them in general to come all the way together. So let's look at some normals, watch breathing, see what's going on there, and see if we can keep our eye on one vocal process, what it is doing. So we're watching here respiration, breathing in and out, in and out. And we're watching the white spot, that is the vocal process. We're going to ignore everything else in the picture. We're breathing out, in, breathing out. In neurolaryngology, there's a couple of conditions that the nerve can be in. Paralysis, where the nerve injury is complete. This is actually rather uncommon, but if the nerve had been cut, there would be no rotation of the vocal process, and quite often other branches would be affected. Much more common is paresis, when there's been a partial injury and there's limited rotation of the vocal process. And then there's the condition of mixed reinnervation. That is, after an injury, the nerve tends to grow from the brain back down into the muscle. And if more than one branch has been injured, the nerve fibers may cross over and go to an inappropriate muscle. And this happens when the posterior cricoarytenoid fibers, the ones that open the vocal cord, some of them go into the lateral cricoarytenoid muscle. And this alters when the vocal process moves. If we imagine that the crossover is exactly 50%, then we get a stable vocal process that neither abducts nor adducts. It's constantly held in a given position. But a little more common is dyskinesis. That is, that we expect during inspiration opening and expiration closing, but if the crossover is inappropriate, we may get some sort of change in the timing of closure, change in the degree, or even the wrong direction when one side is opening and the other side may be closing because of this crossover. So we can imagine there's an area in the brain that activates the lateral cricoarytenoid muscle. So these LCA brain fibers innervate the actual LCA muscle, and we would call this normal functioning if firing in the LCA center in the brain makes the LCA muscle move. And that typically occurs during expiration, which we've just watched, and it occurs during phonation, so that anytime you want to narrow or close the glottis, the LCA part of the brain will fire. So what you're trying to observe is timing during an event. Does the vocal process rotate and move medially during expiration and during phonation? And you can evaluate that timing relative to the other side. So you can look at left and then right and see if there's a delay between one side and the other. You can also look at the arc of rotation toward the midline and that should, in general, be symmetric. Both during phonation, it should be symmetric and complete, and during expiration, it should be symmetric and partial closure, kind of depending on the degree of positive end expiratory pressure that you need. So someone with COPD will tend to close nearly completely the vocal cords during expiration. And you can watch to see if the vocal process is translocating but not rotating. And this can occur if there's competitive tension with the posterior cricoarytenoid muscle tending to hold it open and limit the amount of closure. And it can also be if the LCA muscle is weak and the interarytenoid is compensating and pulling medially without rotating the vocal process. And finally, there's translocation with opposite overcompensation. So the vocal cords look like they've completely closed and lined up, but one side is paretic, has a reduced arc, but it appears complete because the opposite side goes past the midline. So these are some of the observations we can look for. So we're training ourselves to look at each vocal process, and it can be hard to look at them both at the same time. So sometimes you want to slow it down, look at the left, look at the right, and repeat. And let's move on to a case where they aren't symmetric. And here we're watching the right side is acting normally. The right vocal process during respiration is completely opening during inspiration and closing during expiration. And the left vocal process is perhaps moving, and it is moving at the correct time. It is moving medially during expiration and laterally during inspiration, but the degree of rotation is minimal when compared to the right side. We've been watching the vocal processes during respiration. One of their main uses is during phonation, bringing the vocal cords together so you can blow air through and make them vibrate during phonation. And this is when we most want to see them for causes of hoarseness. However, many times the view is obstructed by the arytenoids. The arytenoids sometimes are tipped forward and cover up this vocal process that we've been wanting to look at. The key to this then is to use topical anesthesia on the vocal cords, anesthetize them with lidocaine, and put our camera in. And when we get the endoscope in, we want to go in under the arytenoids, lift them up, and then we can see the vocal processes. Let's take a look at some examples. So here we have a weak breathy voice, but the glottis closes very quickly. The false vocal cords cover the true vocal cords, and the arytenoids cover the vocal processes. So we hear a problem, leaking air, but we can't see what's going on with the posterior commissure. So we'll apply topical lidocaine and have another look. We have our endoscope in the posterior commissure and made a recording. I've stopped the frame here where the right vocal process is essentially in the midline, leaving it parallel to the membranous cord, while the left side is canted laterally, and this leaves a gap on the left side to leak air. The second aspect of this is that any changes in this configuration will be most visualized at low pitch, because at high pitch you activate the superior laryngeal nerve, cricothyroid muscle, and pull the vocal cords longer, and any abnormal opening of the lateral cricoarytenoid will be pulled together. So the superior laryngeal nerve can be used to compensate, and we want to remove compensation. Look at the lateral cricoarytenoid muscle, the LCA muscle, when it's acting alone. So that will be during phonation and low pitch. And when we slow our video recording down, we gain a perspective on how much compensation is actually coming from the right side. The right vocal process is actually pushing past the midline. Here we have three images at high, medium, and low pitch. In the leftmost image, the right vocal process is near the midline, and the left vocal process is canted laterally. As she drops down in pitch, moving across the screen, the left vocal process gets canted further and further laterally, giving her a larger and larger gap, although the right vocal process actually pushes harder and harder at lower pitch, trying to adjust the compensation. Let's review a case where the left lateral cricoarytenoid muscle weakness is subtle. The true vocal cords come all the way together, and if you focus on them, it will seem like everything's normal. And to a degree it is. The thyroarytenoid muscles are in fact fairly equivalent. So if you can get the vocal processes to come together, whether they rotate together or whether they slide together, you'll have a relatively normal voice, except it's weaker than normal because you can't tightly close it. And in this case, to see the subtle weakness, we're going to slow the video down. We're going to watch the onset of phonation, and we're going to watch the right side move medially and rotate the vocal process inward, while the left side tends to translate but does not rotate inward. This is most apparent when we slow the video down. Notice how the vocal process on the right is leading while the vocal process on the left is lagging, both in speed and in angulation. It's even more apparent, her dysfunction during respiration, and that is that when she breathes out, expiration, the vocal processes should rotate, and we see the right side rotating and the left fails to rotate very much at all. And this is another great view of how on the right side the vocal process is rotating and leading the closure, while on the left side it is not rotating and it's being dragged towards the middle. This case is an example of why it's so important to see the posterior commissure. When you first look, the vocal cords don't come all the way together, but they appear to align and they vibrate fairly symmetrically. Her entire anterior branch of the recurrent nerve is affected, so both the thyroarytenoid muscle and the lateral cricoarytenoid are affected. When she breathes in, we can see how the right vocal cord is very atrophic. That's the weakness in the thyroarytenoid muscle. And then we watch on expiration to evaluate the lateral cricoarytenoid muscle. But when you both watch it in slow motion, you can see that there is almost no rotation of the right vocal process. It slides inward. The left one rotates in and the right one doesn't. And it's super obvious when you put your camera in, the flexible endoscope in, underneath the arytenoids. Then you can see the configuration of the posterior commissure and how the lateral cricoarytenoid paresis is the primary cause of the vocal weakness and hoarseness. All right then, I hope these example cases have been instructive and that you're able to focus your eyes on the vocal process and identify when the lateral cricoarytenoid muscle has been injured. I think it's the most missed injury in neurolaryngology,